Welcome, colleagues. Good morning, good afternoon, good evening for those of you joining us from the other side of the planet. We're going to be starting this webinar in a couple of seconds, just waiting for people to join. Bear with us. Welcome. We will be starting in a couple of seconds, a couple of minutes. We have a lot of people joining today, so bear with us. As people are joining, we remind you that we have Spanish interpretation. So you have a little globe at the bottom of your screen that shows languages, and you can choose either the English or the Spanish language channel. Yes, Carly, there's going to be a recording of the session. We're going to go through housekeeping in a couple of seconds. Thank you, colleagues. Welcome. I think, Jill, we can go to the next slide. Welcome, colleagues. Thank you for joining us today. We're going to start with a little bit of housekeeping first. Please, we remember that we have Spanish interpretation, and therefore you need to be choosing either the English or the Spanish channel. And you can see on your screen how to do this. There's a little globe saying interpretation, and choose either the Spanish or the English. Thank you. Welcome, everyone, to the System Strengthening Learning webinar, where we're going to be doing the learning with colleagues from Changing the Way We Care. We're really excited to have you today. We're expecting a big group, so bear with us as we are taking a couple of seconds to let everybody in. Thank you for joining. Carly, I see you've got your hand raised. If you can write it in the chat, that would be great. Thank you. Okay, I think we're going to be starting. Next slide, please. So welcome, colleagues. My name is Florence Martin. I'm the Executive Director of Better Care Network, and it's my real pleasure to welcome you to this webinar. This webinar is actually part of a new series of webinars that we're launching today under the Transforming Children's Care Collaborative, which is focused on exploring learning and innovative approaches and practices in relation to strengthening childcare and protection system. We're looking at the evidence from the practice about what works and what doesn't work about strengthening children's care and reforming them. For those of you who don't know, the Transforming Children's Care Collaborative brings a large group of actors together from all levels, working at all levels around children's care. And its aim is to establish more strategic sector-wide collaboration from global to local levels to strengthen children's care and care systems. And the webinar series, we've done webinars since the collaborative started in 2020, is part of this strategy, which is sharing learning among this community around what we're doing, what works and what doesn't work for children and children's care. So we're really delighted to have you there. There is going to be a link to the in the chat in case you don't know about the Transforming Children's Care Collaborative and want to join. So thank you. Next slide. Okay. So a couple of housekeeping. We've already mentioned that we are having Spanish interpretation as well. So if you're not in your language channel, please join it. Go to that little globe. Also that the webinar is being recorded and it's going to be available. We're going to send to you after today in both in English and in Spanish. Please introduce yourself in the chat and make sure you select everyone when sending a message so everyone can see your hello and who you are, which organization you're from. I've already said about the interpretation icon, very important to make sure you join the right one. We're going to be using the Q&A to ask questions and to upvote and comment on the question of other attendees. So we encourage you, if you have questions or even comment, please use the Q&A rather than the chat. We'll still look at the chat and see whether anyone has posted anything there, but the Q&A is going to be easier for us to see your question and make sure we don't miss them. So welcome. Next slide, please. Okay, so this first webinar, we're going to be learning from colleagues at Changing the Way We Care. They have just finalized a final evaluation of their work for the last 7 years plus that they've carried out in 4 countries, Moldova, Kenya, India, and Guatemala. So colleagues are going to be here with us today to talk about those lessons learned around system strengthening. Why are we doing this webinar focusing on system strengthening? We have a global campaign, which many of you know, that has been launched by the UK government. A couple of weeks ago at the UN General Assembly, the global charter, the global campaign on reforming children's care system has been launched. And this is an opportunity for us as we launch together as a movement in this campaign to make sure that we build on the evidence, we build on the practice that we are all collecting around what works for children in children's care and what works about reforming system. So the agenda today is going to be Joe Wakia, the evaluation director for Changing the Way Care, is going to talk a little bit about the methodology that was used, which is actually quite fascinating, around evaluating the system strengthening work of Changing the Way We Care. And then colleagues from Changing the Way We Care are going to be addressing specific components of the system, including legislation, policy coordination, the workforce, financing, M&E and evidence, and service delivery. So we're going to be learning across all of these, the work of these countries on these key issues. And then they will share conclusion across those contexts, and then there will be opportunity for Q&A. So we're really excited to have you here today, and we look forward to learning from colleagues at Changing the Way Care. So it's going to be my great pleasure to introduce Joe Wakia.
Great. Thank you so much, Florence. It's a real pleasure to be here with you all today, and we are absolutely delighted as the Changing the Way We Care team to be able to have this opportunity to share with you about the evaluation that we have been undertaking to try and synthesize the learning that we've been having over the last 7 years across our different demonstration countries. Delighted to have you with us. Welcome. So, as Florence mentioned, it's my opportunity to tell you a little bit about Changing the Way We Care and the methodology that we followed for this evaluation. I have been delighted to be the MEAL, Monitoring, Evaluation, Accountability and Learning Director for Changing the Way We Care for the last few years, and have been part of the initiative from the beginning. And it is very exciting to be at this point to share these insights with you. So for those of you perhaps that don't know Changing the Way We Care so well, we are an initiative that was set up in 2018 to work across multiple different locations and to look both at strengthening national care systems as well as to promote learning and to influence the work around care reform globally. We chose at the beginning to work in very different contexts around the world in order that we could generate learning that could be synthesized and be applicable around the world in many different locations. So we had a very ambitious vision at the beginning to work in many, many countries. In the end, we ended up working for 7 years in depth in the 4 countries that you see on the screen here. and have taken this opportunity as we wrap up as an initiative to bring the learning specifically around strengthening care systems together across those 4 countries. We wanted to try and answer questions around what really works in strengthening care systems for children. We were guided by the idea of experiential learning. We knew it wasn't just enough to tell the stories of each individual country, but to be able to step back from those experiences, to synthesize and to abstract a little bit in order to create learning that could then be taken up and be useful in other locations. And that is what led us to undertake this evaluation that we're sharing with you today. We decided to follow a realist evaluation approach because it digs a little bit deeper than simply asking, did it work? Were we effective? Instead, it allowed us to explore what works, for whom, in which context, to what extent, and how. We've really enjoyed this opportunity to think together a little bit more deeply than perhaps we had the opportunity to when we were in the thick of the work. The approach has been really valuable, especially dealing with the complexity of systems strengthening. From the very beginning of changing the way we care, we always use this framing of thinking about the care system in each country. In an early publication on the National Care System Assessment Toolkit, we looked, and building on the work that had gone before us, we looked at the 6 main cogs of a care system. As you've heard already from Florence, the service delivery, the laws and policies, the workforce financing, M&E, and social norms. For this evaluation, we wanted to keep this framing, and we have looked at 5 of the 6 of these. We set aside the social norms one as we felt that was a little bit harder to unpack given the data that we had available to us. So one of our core monitoring methodologies as an initiative was to use outcome harvesting to monitor change within the national care systems. Over 7 years, we collected over 460 examples of how the care systems in each demonstration country had been shifting. Change that we had contributed to as changing the way we care, but alongside many, many other actors in each of those countries. And as we built up this pool of examples of change, we began to see different patterns emerging. We saw that change took a long time. So if you look at the blue line graph there, it gradually built and built, the momentum built, and change emerged more strongly after several years of operation. When we categorize our examples of change by using those care system components, we saw that service delivery was the most common type of change that we were seeing, but social norms was the least common. And that's why we excluded it from this particular evaluation. We decided outcome harvesting was not best suited to capture those particular kinds of change. And we found that although government actors were very significant in shifting their own care systems, there were a whole variety of different actors that were playing really significant roles and were shifting their practices and their ways of behaving as we progressed with our work. And so we were capturing a whole range of different types of change across the whole system. And this set of data became very much the foundation of the evaluation that we're sharing today. As we were seeking to understand the outcome harvesting data set, we were looking for ways to explore it in different views and came across the 6 conditions of systems change framework and decided to map our outcomes onto this particular framework. It reminded us to look not only at the most explicit or visible parts of the system, which we were already doing, but also to look at maybe the more subtler shifts that were happening below the surface within the system, such as around relationships or power dynamics or the way that we think and speak about a care system. This really resonated with the data set that we'd already documented because we had already begun to see that we were capturing examples of change that didn't fully fit into one of the categories of the system components. You might have noticed on the previous slide, we'd also started documenting things around commitment or connections and collaboration. And those were the kind of things that using this frame allowed us to see were really important parts of the change process. And that fitted really nicely also with the realist evaluation approach, which helps us to, as I said, to dig a little bit deeper. So in order to bring these pieces together, we followed a process that fits really nicely with a realist evaluation approach. Which is a theory-based approach to evaluation. So we went back and found our original theory. We had a theory of change, but we also went back and dug into the original planning documents that we had, the proposals that were written in the very early stages, and drew out those ideas around how we imagined that change would happen within care systems. We then revisited our outcome harvesting data and got to look at it in a slightly different way that we had before, picking out different types of change that were happening across the system components and seeing how they built chains of causal pathways together, and tried to think differently about maybe what had driven those different change processes. We also got to conduct 12 interviews with government, civil society, and faith leaders that we'd been working alongside, and to hear from them how they felt about these examples of change that we were beginning to explore in a different way ourselves, and to have conversations with them about their experience of change. We brought all of this information together and with a smaller team analysed that data, looking for different patterns of change within each country, and also to look across all of the countries for commonalities and differences that were happening in how change unfolded in the different systems in each country. All the time, we were working as a diverse team, many of whom you will hear from today, trying to draw out different insights about this change process from diverse perspectives. And we're really excited to be here to be able to present to other actors today. We've had other opportunities to share with people, and we do hope that this is a continuing process of refining our theories and ways of thinking about system strengthening. As I've mentioned, we used a realist frame for our analysis, and that meant that we went looking for examples of how contexts had impacted the way that change had happened. And we looked for the interventions that we had brought in and that others had brought to the table to influence change within the systems, and to explore how those interventions in that particular context had triggered different mechanisms for different actors and led, therefore, to different outcomes. And for us, this idea of mechanisms was a new thing. We recognized it resonated with this idea of looking below the surface and looking for the hidden pieces of change. And a good way to think about a mechanism, an analogy that we really liked, is if you imagine that you're holding a tennis ball and you release it. If you're on a tennis court, the ball will drop down and bounce up. If you are an astronaut out in space and you release a tennis ball, it will hover there for a moment and eventually float away. But if you're a diver under the water and you release a tennis ball, it will bob up to the surface. So although it's the same intervention in all three cases, just releasing a ball, because the context is different, because the actors are different, you get a different result at the end. And so we were particularly interested in trying to unpack these mechanisms that were at play that might not be immediately obvious. So we would be presenting to you in this, some of what we present will be in this format of looking at the context around the state of the system and how things have evolved within that system, and then the wider influences around the interventions, the activities that we have introduced as changing the way we care, the mechanisms, these processes of change that might not be immediately obvious, and the outcomes, the results that we saw. We generated CIMO chains like this for each country, for each system component, that are a simplified representation of reality, but helped us to kind of unpack these connections. And then we looked across those chains for each country, for all of the countries together, and generalized them and pulled out the common features that we felt were true of the change process in each of the system components. And we're sharing a very simplified version of that with you today. Our full report will have a lot more detail in there. But we also want to recognize that there were some limitations to the way that we were working. So for your information as well, our outcome harvesting data only includes what we observed as the changes that happened, things that we considered to be significant and that we recorded. Although we did go through several substantiation processes as part of earlier evaluations, it is one perspective on how change has happened. We focused on systems level outcomes. We didn't have the opportunity to dig down to children and family level outcomes. That's something that's really important to do. We had other monitoring methods that were going on alongside this, but we haven't been able to bring those pieces together as part of this evaluation. We should flag that we are new to realist evaluation. We've all been on a steep learning curve, but I think we've all really enjoyed using this approach, and it's opened our eyes to understanding of change. But it's definitely not going to be a perfect example of a realist evaluation. And unfortunately, we were somewhat limited in our resourcing and in our timing, unfortunately, due to USAID terminations. That meant that we squished up the process that we had originally planned and did it all remotely, but we did still manage to do 12 interviews. We would have loved to have done a lot more. We had to do all our analysis remotely. We had some help from AI along the way. We tried to do that as ethically and safely as we could, but we recognized that we would have loved to have had more time to dig into all of this in person. And we originally had planned to speak to many, many more colleagues after we had completed our evaluation and to try and keep this synthesis moving with examples from outside of changing the way we care. We haven't had a chance to do that, but we hope that's something that could still happen down the road. So the evaluation really has been a valuable chance for us to reflect and synthesize. We feel we now have a clearer picture of how systems change has happened across our different countries and how it can happen in different locations. And we're really excited to be able to share these lessons in the hope that it will inform the work moving forward, especially building from the global campaign that is now underway. So it's my pleasure now to hand over to Beth Bradford, who was a key part of our Changing the Way We Care team for many, many years. And she will introduce various other colleagues who are going to be able to share more of the findings that we found from the evaluation. Thank you so much.
Thank you, Jo, and I'm so excited to be here and just thrilled to have been asked to be part of this webinar and part of the learning process. Hello to many familiar faces. It's really, really great to see the interest on this call and to share our findings with you today. What we're going to hear now is more about the original plans of Changing the Way We Care, the actual outcomes, but also the stories of change in each country. We'll hear about some insights on what worked, but also what didn't, and more about the context, interventions, mechanisms, and outcomes for those 5 systems components that you see on your screen. We want to recognize, of course, that these stories of change have been influenced by many actors, and Changing the Way We Care's contribution is just one amongst many. We don't have time today to go into all the details, but what we hope to do is to present an overview of the change that we've seen and the role that Changing the Way We Care played alongside those many others. We're going to hear from different voices representing the diversity of places in which this work has happened, and hope that it'll really show how everyone has come together strongly as a team to understand the cross-context lessons. So without further ado, we're going to go first to Khadija Karama, who is in Kenya. Khadija has been a dedicated advocate for children and families for over 20 years and is the Deputy Program Director and Technical Lead for Changing the Way We Care Kenya. Khadija is going to tell us the story of change around legislation, policy, and coordination. Over to you first, Khadija.
Good morning, good afternoon, everyone. Happy to be here and, to present some of the findings we had as a result of this work. So when Changing the Way We Care began initially, the aim was to basically strengthen local and national legislations, policies in line with the UN, guidelines for alternative family care, and address the gaps in the implementation through system strengthening strategies along the way, with the aim of also, doing that through advocacy and capacity building. Initially, it was assumed that building positive relationships around a shared language of care reform would be important. And it was hoped that undertaking care system assessment and demonstrating approaches to case management, reintegration, and transition of residential care would finally inform policy decisions and reforms. Well, across the initiative, we collected around 34 examples of change in legislations and policy through our outcome harvesting work. As you might expect, most of these changes were with government actors and at the national level. When changing the way we care started, all 4 countries had governments who showed interest in care reform. They also had laws supporting family care, and this was seen as a key entry point to care reform. We found that high-level advocacy, backed up by relationships, sharing of evidence and experience, led to policy change. For example, in Moldova, a national situation analysis shaped the new national program for child protection against which reforms are taking place. In Guatemala, evidence from unification cases persuaded leaders to elevate family strengthening and foster care nationally. Formal partnerships also reinforced these shifts across all the 4 countries. Memorandum of understandings and new or revitalized coordination bodies, like in Kenya, the Kenya's care reform core team were also noted as key aspects of, advocacy level. At the local level, building political buy-in and offering technical accompaniment was just as important. In Kenya, for example, a county known as Nyamira translated the national mandates into local child protection and disability policies. Informed by country networks of people with lived experience and disability organizations, in India, district action plans were developed with support from consultants embedded within the district structures within Odisha. Well, political delays slowed progress at times, but adaptive and collective problem solving kept the momentum alive. For instance, although we attempted to undertake a national care system assessment in Guatemala, it was found that the division of responsibilities across multiple government agencies and the lack of familiarity with the system's view of care reform meant that this was not an effective approach at the time. Instead, adjusting to focus more at the subnational level was more fruitful. Municipal leaders in Rio Hondo, for example, motivated by data on family separation risks and inspired by neighboring Zacapa, approved the country's first municipal public policy for family strengthening. We can summarize our findings using the CMO approach, which Joe mentioned earlier. So in context of growing commitments and strong legal mandates for family care, but with implementation gaps, budget shortages, fragmented responsibilities across ministries or level of governments, the intervention, which included high-level advocacy with evidence-based solution, formalization of practical coordination structures, which include diverse actors, accompaniment for officials in drafting policies and guidelines, and demonstrating the feasibility of these approaches through implementing pilot models will actually trigger mechanisms such as growing political buy-in from senior officials, which reduces bureaucracy, inertia, and resistance, greater credibility from multi-actor engagement, increasing confidence and feasibility of care reforms, and increasing government-led coordination, and ultimately leading to outcomes such as the establishment of formal coordination bodies and strategies and the adoption of new policies, regulations, and procedures with allocation of linked budget. We also noted that crises like COVID-19 can further expose policy gaps, and motivate key actors. And that changes in legislation. As a result of that, policy and coordinations are closely linked to changes in service delivery, as well as workforce and financing. Many service delivery outcomes were only achievable if the legal and regulatory frameworks had also shifted. And that's basically how we saw in terms of the outcomes under legal and policy and coordination care system component. Thank you.
So interesting, Khadija. I think what's really amazing is how you're able to speak to the changes across countries, well beyond Kenya. We're going to zoom over next to Moldova and Viorelia for the story of change around the social service workforce. Viorelia Moldovan Batrinak is the program director for Changing the Way We Care Moldova and a longtime advisor to the government. Viorelia, over to you.
Thank you, Beth. Hello, everybody. It's really a pleasure to join all of you in this special context and to share the changes and lessons generated during the implementation of Changing the Way We Care project regarding the social service workforce as an important component of the system. Changing the Way We Care's original plan in regard to social service workforce was twofold. Firstly, to build the capacity of workers and managers by providing training and support to demonstrate good practice around case management and supportive supervision practices. And secondly, to work closely with government and civil society to develop or adopt national guidance and toolkits around key processes that were missing and to embed linked training through alliances with university and government training institutions. We harvested 19 outcomes on changes in the social service workforce across Kenya, Guatemala, and Moldova from 2019 to 2025. These were mostly at the subnational level and amongst government actors. They included shifts in attitudes and understanding, new provision of training and learning opportunities, enhanced service provision or innovation in practice, and improved collaboration and partnership. A focus on the social service workforce was strong from the start of Changing the Way We Care in all countries, but was often met with resistance. Court officials in Guatemala doubted the capacity of families to care of their children. Residential care managers in Kenya resisted change in the face of confusion around the registration of the institutions. And social workers in Moldova were hesitant about the institutionalization, particularly of children with complex disabilities. These barriers were addressed through multi-stakeholder working groups to refine case management tools, training in case management and supportive supervision, accompaniment during child and family assessments, and peer learning exchanges. For example, in Kenya, Changing the Way We Care worked with Directorate of Children's Services and networks of charitable children's institutions to deliver training in 4 demonstration counties where Changing the Way We Care partners were also implementing new approaches. This clustering of training and demonstration with close government alignments allowed confidence to increase as workforce supported each other. Sustainability was achieved by embedding workforce strengthening in formal systems. In Moldova, for example, a memorandum between Ministry of Labor and Social Protection and universities created a pathway for training new social workers at the national level, whilst in Guatemala, university curricula and internships were linked to family strengthening in specific demonstration areas. When we bring these different country experiences together, and think about these changes through the lens of realist evaluation, we found that in the context of national mandates for reform, but a social service workforce that is undervalued, limited in capacity, and resistant to change, and where national training and support systems are not embedded and universities are not engaged, then interventions which provide targeted capacity building and accompaniment of workforce include close collaboration with university, social work education, and government training institutions, support the collaborative development of standards, tools, and pathways across government, civil society, as well as academia. We trigger mechanisms such as growing professional legitimacy and confidence as skills are recognized and validated, increasing trust through government and academic involvement, which makes sustainability more plausible and normalizes the use of new tools and approaches, and shifting power dynamics as resistant leaders lose influence and the workforce sees children thriving in family care, resulting in outcomes in training being institutionalized in national curricula, greater buy-in from both the workforce and local authorities, systematic use of case management and family strengthening approaches, and the workforce becoming more empowered to influence decisions on children cases. Changes in the workforce were unsurprisingly closely linked to changes in service delivery. These changes were mutually reinforcing. Finance and monitoring and evaluation outcomes were also closely linked with greater allocation of financing, leading to the improvement in workforce capacity, and workforce training, leading to improvements in data collection and their use. Thank you. That's all from my side.
Thank you so much, Fiorelia. It's so fascinating to really think about, but also see how the workforce development links to these other components of the system and how strengthening the workforce really reinforces them. It should be really telling to hear now the story of change related to financing. We're going to hear from Fidelis Mathoni, one of Changing the Way We Care Kenya's senior technical advisors. Fidelis is bringing experience with disability inclusion, participation, and community behavior change. But today she's going to share insights on finance. Welcome, Fidelis.
Thank you, Beth. Good morning, good afternoon, colleagues, and I'm happy to discuss the issue of financing. When Changing the Way We Care was originally conceived, there were some very ambitious aims for how the funding on residential care, especially donations from overseas, could be redirected. It was hoped that financial modeling and evidence, such as investment cases and cost-benefit studies, would be key to convincing governments and donors that care reform could be sustainable and scalable. In reality, this was the hardest area to achieve. We eventually recorded 37 outcomes in relation to financing, but well over 50% of these were in the last 2 years. The vast majority of financial outcomes harvested were at the subnational level, even amongst government actors, not overseas as we had hypothesized. Across Changing the Way We Care countries, financing for alternative care was historically concentrated in residential care. Fiscal constraints, dependence on donors, and entrenched norms around residential care were major barriers. Change emerged in Moldova through cost-benefit analysis and EU-aligned advocacy. This persuaded decision makers that family-based care and family strengthening were both efficient and politically advantageous. The Ministry of Labor and Social Protection responded by increasing national allocations for family support support, foster care, and disability-focused programs and services, committing to ending institutionalization. Similarly, at the subnational level, in Guatemala, documentation and advocacy around service gaps to prevent separation convinced mayors to allocate budgets for establishing municipal offices for children and adolescents in Zacapa. When we look at India, Odisha state, simplified tools helped local officials translate the Mission Vatalsya national mandate into local action. District collectors learned how to use a dedicated 5% of untied local funds for child protection, scaling services at the local level. In Tamil Nadu, engagement with Catholic bishops reinforced care reform messages within church structures, leading parishes committees to provide monthly support to vulnerable families instead of sending children into residential care. When we come back home here in Kenya, new county level policies in line with the national strategy opened space for dedicated county budget allocations, whilst direct engagement and support to residential care providers encourage a redirection of their own resources towards community-based and disability-inclusive services. When we synthesize the country experiences in terms of context, intervention, mechanism, and outcome, some interesting insights emerge. In the context of existing policy and legal mandates for care reform, but with implementation gaps, fiscal constraints, or rigid spending rules and entrenched norms around residential care, respond to interventions which bring together evidence-based advocacy from studies and pilot models with multi-level advocacy and technical assistance, and will trigger mechanisms such as increasing credibility and feasibility of reforms as they are backed by fiscal evidence, comply with national strategies or mandatory allocations have been shown to work in practice, increasing legitimacy and reducing resistance from engagement of political, local, and faith leaders. This eventually leads to outcomes such as government and non-government donors allocating and redirecting funds towards family-based care and social services, and faith-based organizations once focused on residential care, committing financial and in-kind support to strengthen families and prevent separation. In conclusion, our experience showed that financial outcomes were the slowest to emerge, often needing to wait for policies and guidance to be in place on which financial commitments could be pegged, and for some service changes to have been made by early adopters or through pilot models. Thank you, and over to you, Beth.
Thank you, Fidelis. You know, I can remember when we were developing the initial concepts around changing the way we care, and we really thought finance was going to be one of our first areas of input and influence. We've learned so much. Webinar participants, we hope you're beginning to hear some common threads across these components. We'll definitely have time for your questions. I see one that's come in already. Please do use the question and answer space, and we will come to your questions for sure. Now, Sasha Safronova, our monitoring, evaluation, accountability, and learning specialist, is going to come up and tell us about evidence monitoring and evaluation. Welcome to you, Sasha.
Hello, everyone. Excited to be here and share with you what we learned about evidence and M&E. The initial plans for Change the Way We Care included strengthening the availability and use of data related to children in care. All demonstration countries lacked a comprehensive M&E framework and a well-functioning management information system, or MIS. The original intention was to invest in these MISs and to train key actors at multiple levels in order to improve data. However, in our outcome harvesting dataset, M&E outcomes are among the least common, with only 14 documented in total, 8 from Kenya and 6 from Moldova. And these are mostly national level changes among government actors. Although there were some early outcomes recorded, most occurred from 2023 onwards. We found it was hard to address the limitations in M&E directly. As we look back, we can see that a key factor in strengthening M&E was finding moments in the wider reform process where new or improved data could unlock progress and show the benefits of having reliable data and systems for its collection. One of the first activities in Kenya was a situational analysis of residential care in 5 counties. The participatory process with visible government leadership meant it went well received and was replicated in other counties and by other actors. In Moldova, a deep dive analysis of different parts of the care system brought civil society and government stakeholders together and informed planning. In both countries, the successful first steps created demand for more. In Kenya, during the COVID-19 response, children moved from institutions to families with little preparation or ability to provide support. Working with the National Care Reform Team, Change Web Care carried out a rapid data collection on families' needs, highlighting the importance of reliable data. Subsequently, the Directorate of Children's Services prioritized MIS improvements and eventually added alternative care to their work on updating the Child Protection MIS. Change Web Care collaborated on this and led training and peer learning events. In Moldova, high-level government engagement using an evidence-based roadmap for deinstitutionalization led to a demand for improved monitoring of children remaining in institutions. Change Web Care supported rollout of this data collection through existing systems, collaborating closely with Data for Impact and the overall government effort to update MIS. By stepping back and switching to the next slide, so when we look at these country examples through CIMO lens, we begin to see clear patterns of change. In contexts where governments have a clear strategy for care reform, but M&E systems are weak or under-resourced and underused, and service providers don't fully engage with national data processes, interventions like high-quality assessment under government leadership to inform decision-making and collaborative improvements to MISs, aligned with national strategies and embedded in existing mandates, supported by capacity building, will then trigger mechanisms including increasing trust and credibility among leaders, reducing resistance and building shared ownership among local workforce and service providers, increasing buy-in and motivation to scale approaches. And in this case, outcomes we can expect are the following. Data is being used to inform immediate plans, governments request further data and invest in M&E systems, and local actors institutionalize improved data collection. We have seen that improvements to data collection and use can influence changes in policies and finances. But this approach also requires greater workforce and coordination capacity to operationalize administrative data collection systems. It is interesting, though, that we didn't record outcomes around M&E in 2 of our countries, which shows the challenge of finding right ways in to improve this part of the system. Thanks, everyone.
Thank you, Sasha. I'm so glad you're raising some points around the challenges. I think, as we've said, it's not been an initiative without challenges. It might be easy for us to talk about positive impacts, but as a learning initiative, the challenges and the shortfalls were also really important. Now, finally, we're going to dive into the story of change related to service delivery. And to do that, we're going to zoom over to Guatemala and the Changing the Way We Care program director, Roberto Tejada. Roberto is an amazing advocate for family strengthening and government systems change. Roberto, what did we learn about service delivery?
Thank you, Beth. Greetings all from Guatemala. Well, Changing the Way We Care demonstration approach was clearly outlined in the plans for strengthening services. Initial plans included the development of strong case management approaches and the training of key actors in these approaches and the accompaniment residential care providers to transition to family and community services. This hand-on approach led to a huge change with 78 outcomes harvested in this category. More than half of these outcomes were about changes in practices within residential care providers, and another 31 outcomes related to improvement in gatekeeping, family support services, and disability inclusion. So national outcomes were some of the first to be achieved, whilst national changes such as the endorsements of plans and tools took a little bit longer, but were then related to further local outcomes. Although there were differences in approaches across the four countries, the most common entry point was building the knowledge and skill of service providers in case management. This was recognized in our year 3 evaluation as a powerful entry point since it neutralizes objections as it is clearly child-centered and aimed at reducing harm. Clear guidance, standardized tools, and supportive supervision reinforces skills and confidence. And it also empowered local actors and created champions for change. From the director of Secretariat for Social Welfare in Zacapa, Guatemala, to residential care managers and sub-county children's officers in Kenya and social assistants and NGOs in Moldova. Relationship building was also critical and key to the endorsement and scaling for new practices. This came through revitalized local networks and national core group in Kenya. In Guatemala, for instance, Commission for Children and Adolescents linked the Secretariat for Social Welfare and Civil Society. In both India and Guatemala, additional staff were seconded to local authorities to work alongside teams to implement new approaches. While in Moldova, conferences and technical task forces united ministries, local authorities, NGOs, and donors. Across all four countries, support was provided for residential care providers through technically accompanying them on their journey of transition. And finally, government buy-in and evidence from international good practices were also essential. Embedding tools and approaches in official policies and systems align service providers with national priorities and directed funding to new services. In Moldova, also European Union accession requirements reinforce this momentum. Evidence-based approach influenced actors to adopt new practices, which then made them visible and credible for others. If we go to the next slide, when the country finders our map onto the CIMO framework, we find that talking about in context where there is momentum for care reform, but fragmented service provision and weak coordination and accountability. The interventions such government-endorsed training and mentoring of service providers, multi-stakeholders, and evidence-based dialogues to develop government-endorsed guidelines and tools and engagement with faith and community networks engaged through sensitization, alignment with moral values, and co-design of family support services. This will trigger mechanisms such as building legitimacy and trust by showing visible government commitment and fostering multi-stakeholder engagement. Also, growing understanding of the viability of change and grow in skills and conviction through learning by doing. Changing attitudes and reducing resistance from endorsement by respect, faith, and community leaders in alignment with moral, religious, and also professional values. And the normalization of new approaches through peer examples. As a result, outcomes can include national and state authorities beginning to adopt new driver forms in service delivery. Coordination mechanisms become more functional. New stakeholders engaging in multi-stakeholder groups spreading reform messages and successful pilots being replicated and scaled. For children and families, this means local service provisions improves, case management is strengthened, admission into residential care are reduced, and gatekeeping and referral pathways become more functional. It is clear that improvements to service delivery go hand in hand with, number one, strengthening workforce capacity, and that many service delivery outcomes are only achievable if the financial resources have also shifted or mobilized. Thank you. Back to you, Beth.
Thanks, Roberto. It's so great to hear your voice and see your face. You're really bringing us back to those interesting lessons that connect each of the components one to another. I'm really pleased now to pass the mic to my longtime friend and colleague, Kelly Bunkers. In addition to being the senior advisor to Changing the Way We Care, Kelly is a senior associate with Maestro International, a council member at Faith to Action, and a senior fellow at the Georgetown Collaborative on Children's Issues. Kelly, I think you're going to attempt to bring it all together for us. So over to you.
Thanks, Beth, and thank you to our fabulous presenters. Yes, I will definitely present some of these key themes that came from our realist evaluation. So looking across the system components and throughout our evaluation process, some very clear themes emerged on how systems change or system strengthening unfolded. Number one, evidence and demonstration as catalysts. In all components, evidence-based advocacy and pilot models were critical. Demonstration work in case management pilots, situational analyses, cost-benefit studies, and family strengthening services all legitimized reforms, reduced resistance, and showed decision makers that change was feasible. 2, government ownership as critical to reinforce and sustain change. Reforms gained traction when government actors assumed visible leadership and coordination roles. This included ministries, councils, and municipal leaders. When they drafted overarching strategies and endorsed guidance, this legitimized the changes and shifted them from an ad hoc project to institutionalize sustainable reforms. 3, partnerships and multi-stakeholder collaboration. Across all areas, diverse coalitions such as that made up of government, NGOs, faith leaders, academia, donors, and communities created legitimacy, accountability, and momentum. Formal structures like core teams, commissions, and memoranda of understanding helped institutionalize these relationships. 4, capacity building as an entry point. Training, mentoring, and technical accompaniment, as well as peer learning, were very effective strategies that not only strengthened skills, but also shifted attitudes and increased trust and confidence. 5, alignment with broader agendas and values. Change was often unlocked by framing reforms in terms of existing priorities or norms. For example, EU accession in Moldova, decentralization in Guatemala and Kenya, Mission Vatsalya in India, or religious values in faith-based contexts, aligning with what already mattered politically, economically, or morally, created powerful incentives for adoption. And the final one, adaptive problem solving in complex systems. Across components, progress often required navigating blockages. This included stalled councils, resistant leaders, resource shortages, or in some cases, a change in government. Through flexibility, alternative pathways, or opportunistic engagement with champions, adaptation was a shared mechanism to sustain momentum. Plus, we've also learned the interlinkage of system components, as you've heard today, how it changes in one affects or is impacted by changes in another component, and therefore the importance of a holistic approach to system strengthening. This will be a challenge as the funding landscape for children's care reform has substantially shifted in the past 6 months. There is a need to tackle systems change with a whole of system, long-term view to achieving sustainable system strengthening. The importance of adaptive management and recognizing that not all plans are feasible in practice. Changing the way we care had a big ambition when we started more than 7 years ago, and a lot has been achieved alongside our many partners. But reform is a long process and an ever-changing environment. So being able to recognize when things are not working and adapting to this is a key strategy. As one colleague reflected recently, our initial desire was to embrace our failures as well as our successes. This was uncomfortable and hard for many of us, but now she can see how much learning and progress has come from this. And finally, the usefulness of outcome harvesting for monitoring and evaluating system strengthening, and the good fit with realist evaluation for understanding system strengthening below the surface. This is the first evaluation to use a realist approach on children's care system. It's been used on health system strengthening interventions, but it's the first time for this topic. It's important, therefore, that we continue to increase our understanding of what works in which contexts and why. Therefore, we hope that there will be a way in collaborating with our many partners through the Transforming Children's Care Collaborative, that this can continue and that there can be added experience from other contexts to enrich this evaluation. Thank you. And I think we are going to move on to questions. So let me just see here. Okay, I think we have a question for Hadija. Hadija, what were some of the main barriers to redirect external funding toward family care? For example, funding from outside the country. You could turn your camera on, Hadija, and give us a response, please.
Thank you so much, Kelly, and thanks, Severine, for the amazing question. So when we started off, the idea of understanding what care reform is from the people in country, for example, the institution that we're working with, organization that we're working with, was a big challenge. And what really happened in terms of starting off, the focus was on the workforce and, trying to push the agenda of institute, but forgetting the people who matters the most. For example, first and foremost is bringing in the aspect of messaging around what this means to the people who own the institution, the donors of the institution, the board of management. So that's something we came to realize later in the implementation, that for you to start to instill change and contribute to getting, redirection of funding, there's need to have correct messaging, the right way of doing advocacy to, the donors, to the founders, to, the board of management of organizations and institutions, for them to really understand the change in this investment and what this change in investment means. So I think for us, coming to know that along the way through our adaptive management, it is something we realize. For you to start conversation around redirection on financing, you need to know who matters the most to be talked to, what is the right messages, because the way you will communicate to the donor and the way you communicate to the board of managers, to the founders, somewhat is different as much as the messaging is the same. So that's the biggest hindrance, or rather the gap that we realize, and it is something that is being worked on. For example, in Kenya, we have a national documents around the care system assessment, what it means to transition from institutional care to community and family-based care, and what investment does that bring in, so that at least they're able to see the investment towards the end in terms of redirecting those resources. I hope that answers the question. Thank you. Back to you, Kelly.
Thanks, Hadija. And I think we're going to turn now to Roberto. Roberto, I'm going to combine two questions about children and families. So how have we measured impact or results on children and families? And what do they say about changes at their level? Thanks, Roberto.
Absolutely, Kelly. Thank you. That is a good question. We see that we have a great opportunity. We have seen that approaching services and getting services closer to the community at a community level make a significant difference. In Guatemala, there are 360 municipalities, which is our country is divided by states, departments, but in other countries, in Guatemala, we have found that if we get these services closer to the community level, it makes a difference, because sometimes there are no psychological services, parenting classes, access to basic education on family care at a community level. Families, as we have found out in our surveys and our household surveys, say that when they find these opportunities at a community level, they have more tools to communicate with their children, and this translates into the opportunity to keep families together. I remember one short story about a lady saying that they didn't have any after-school programs at a community level. When we were working with this municipality at the east side of the country, we found out that as simple as it seemed, bringing after-school program brought tools to families in order to communicate better with children, in order to children to stay at schools and not drop school. So I think that what they have said about these changes, it translates into basic services, approaching those services to the community level.
Excellent. Thanks, Roberto. And I just wondered, Joe, if, not to put you on the spot, but if you might complement what Roberto said regarding some other evaluations where we've been able to explore the impact on children and families.
Yeah, thanks, Kelly. I think, as I mentioned a little bit earlier, we did have other ways of understanding what was going on right down at the child and family level. And as Roberto just mentioned, we undertook 2 rounds of a household survey in Kenya and Guatemala and 1 round in Moldova. And that really gave us an opportunity where we were providing demonstration direct services to children and families to be able to understand how those were having an impact on children and families. And it was really fascinating for us to learn the variations between the countries. We saw really positive results coming through a very structured process that had been followed in Guatemala, and saw huge increases in caregivers' protective factors and in children's well-being across a range of domains that actually children helped us design those questions. So domains of well-being that they considered to be important, particularly for children who were reintegrating to families from residential care. Through the same process in Kenya, we found, because case management processes had been very disrupted due to COVID, and because of the higher levels of poverty that were being faced in communities in Kenya, that there were still ongoing issues for children once they reintegrated back home. So although the care that they missed in residential care was definitely present now that they were back in a family environment, the families themselves were still struggling to ensure full access to services that they needed for their children. And across all of the countries, we found that children with disabilities had lower well-being. And so it was really important for us to be able to get those insights from the ground, and that definitely informed the way that we then move forward with the programming and input into some of those systems level work that you've been hearing about. Thanks.
Wonderful, Jo. Thank you. Okay, there's another question here, and I'm going to ask Viorelia if you might respond. Has changing the way we care explored any mission-aligned roles for businesses beyond philanthropy that could complement civil society and governments in care system strengthening?
Thank you, Kelly. Our first experience in piloting was a collaboration with a faith organization. And also we, during different mission regarding the children with the institutionalization of children with disability, prevention of children separation. Of course, we worked with various actors. That was university from the country and abroad. That was commercial banks, which one nice example, they help us in improving the financial literacy of vulnerable family and children. And medical university also provide in the context of prevention measures, the development of healthy behavior and oral hygiene and some other elements. And based on that activities, local authorities signed a long-term contract in order to help the family and to develop a better social norms in child care and family and child relationship. And there are some many other examples which are centered on better child care and development.
Excellent. Thanks, Fiorelia, and thanks to everyone who is sharing questions. We're trying to get to them. I'm going to combine two questions on sustainability. So, how did changing the way we care define and measure system level change to capture deeper policy, institutional, and attitudinal shifts, including those beyond its direct interventions? So I'm going to see if maybe we could get some short responses from Hadija in Kenya, Fiorelia in Moldova, and Roberto in Guatemala. So how did we define and measure system level change? Who wants to go first? How about Hadija?
Yeah, so thank you so much, Kelly, and the person who asked the question. I think at the level of changing the way we care, we knew the importance of measuring change and the importance of ensuring sustainability. So in our approaches from the word go, what we adopted is government-led, government owned process, and we started this process together with the government. But then at the level of changing the way we care, we reached a point where we asked ourselves, how then do we want to ensure we measure, sustainability? And we went down to do a quick assessment of our different approaches that we had, figure out what it meant in terms of scaling. If someone is supposed to scale, how do you do that? But also went ahead and developed what we called a sustainability matrix, that we embedded within the matrix some, simple milestones that would help us to measure change. Unfortunately, we couldn't see through it, completely, but along the way, we were able to really measure it. We used that to inform us in terms of, okay, in the next 2.5 years, we know we are no longer going to be here. What exactly do we want to ensure that this sustainability is actually realized? And some of this included, making sure some of these documents are taken up, are implemented by the government themselves. They take up that leading role in disseminating and making sure they implemented, embedded it into their national policy. So those are some of the things we managed to see. And we were, like right now, we are able to see at the country's level in Kenya, that government has taken up some of these, and not only at the level of the State Department Children's Services, but anything that deals with child protection workforce. So that includes National Council of Children's Services, Directorate of Social Development, especially in terms of workforce capacity strengthening. Yeah. Thanks, Kelly, and back to you.
Thanks, Hadija. And I'm going to ask Roberto if you might provide a response to this, please.
Yes, thank you, Kelly. I think when government part, which is responsible for family care, starts taking ownership and lead others by adopting methodologies and tools and start mobilizing resources and actually takes leadership, that's when sustainability starts to happen and the system levels start to change. We have seen, especially in this last phase of changing the way we care, when we have been working closely with government authorities, that they have been taking leadership and changing the way we care has been stepping back and giving leadership to government who is responsible for family care. And government start not only mobilizing resources, but assigning specific leaders to transfer these methodologies and bring others for family care. That's what we can say about how system starts to change in this level.
Excellent. Thanks, Roberto. And back to Moldova. Viorelia, can you respond to this, please?
Thank you. Thank you, Kelly. I want to mention that one of our great lessons is that change is sustained when interventions build legitimacy, trust, and shift power dynamics. That's why in area of social service workforce, for example, we shift from temporary fragmented training of the workforce based on the possibility of external donors or national partners to embed the workforce development in formal system and in academic institutions, which will be continuously planned, organized, based on competency standards, will be assessed, will give the possibility to grow in, to ensure the career progress for the workforce. And also it's very important to support the workforce with professional tools, like it was developed case management or different guidelines which ensure the quality of service delivery. Thank you.
Excellent. Great. Thanks all. And I think it's important to just remind ourselves that when we were designing the initiative, we really used the guidelines for the alternative care of children to help inform sort of what we needed to work towards, what success might look like. So that was foundational across all of the countries. Thanks so much. Okay, I think one more on government ownership. So you said government ownership was crucial to sustainable reforms. The question is, could you talk about what this looked like when it was done really well, or what embodied best practice of government ownership? And I think I'm going to ask Hadija. Oh, it looks like Hadija is typing an answer, but maybe you can say it instead, Hadija. Thanks.
Yeah, thanks again, Kelly. An amazing question. So in Kenya, when this agenda began, what we did is we went for the top, the big, for the lack of a better, the decision makers in Kenya. So got hold of the ministers, the principal secretaries, the directors, assistant directors, to get to understand the agenda of care reform and what it means, the impact on children, and the investment in children. So this involved us bringing them together and getting people who have had experience in care reform and really having a candid conversation on that. Then this also went ahead where we had some in-country exchange visit. A team went to Rwanda, colleagues, traveled to the US so that they could actually see, the reality on the ground, understand the challenges, really just to understand that it's not easy, but it is something that is doable. So getting the top level decision makers buying into this idea, it really paved the way for, we had the go away from the government. We had the senior government implementers were actually put to accountable in terms of, yes, we know this is what is happening. This is what Kenya has signed for. We want to see the change. And that has really helped us as a country to have policies in place, to have strategies in place that are supporting this, and really getting to have some level of accountability from senior government officials when it comes to issues of care reform. Yeah.
Excellent. Thanks, Hadija. And in the interest of time, I'm going to ask Roberto and Viorelia if you could perhaps respond in writing to that question, giving some examples from Moldova and Guatemala, what government ownership looked like when we say it's good practice. There is a question for me that I will try and respond and then perhaps ask colleagues to add to. It says, from your experience across Kenya, Guatemala, and Moldova, what tangible value did the engagement of care leavers bring to this movement? And how did their lived experience and leadership influence learning strategy or sustainability with the program? An excellent question. And I think, as we saw in the presentation, the meaningful participation of those with lived experiences, including care leaders, was instrumental and was integrated throughout the initiative. I think one of the most important ways that it influenced, let's say, us as an initiative first, was really learning how to engage well and how to engage in a way that kept care leaders both meaningfully participating, but also safe. And I think, as we talked about earlier, the initiative really looked at our successes as well as our failures, and I think tried our best to learn from that. I think across all of the countries, we have tried to be very strategic, recognizing and trying to find really unique value add opportunities for care leaders specifically to engage. And I know in Kenya, for example, in co-developing guidance on how to engage with care leaders, developing life skills, and really, I think in Moldova, kind of working alongside and creating opportunities where care leaders could lead in research, could help design questions. And I think another really valuable way that we have influenced or learned from or engaged with was opportunities where care leaders in different contexts could actually engage with virtually each other and inform the work that they're doing in each of the countries. So I think, yeah, across all countries and at the global level, there's been a powerful learning curve, and I think a really unique and important contribution by those with lived experience. And I don't know, Beth, I'm going to put you on the spot if you might want to add anything to that.
I guess of a couple of really concrete examples that I can share quickly. One was that the representatives from the Kenya Society of Care Leavers were engaged from the very beginning in national level discussions about the national strategy, working groups, et cetera. So again, just really concretely ways that care leavers were engaged in Latin America. We supported a mapping of care leaver networks so that they would learn about each other, but also so that organizations knew who to go to when really trying to meaningfully engage care leavers in different processes at a country level, but also regionally. So just a couple of concrete examples. I think we have Changing the Way We Care has shared a lot of learning on participation via Better Care Network. So you can look for those resources. All of those were developed in collaboration with and hopefully supporting meaningful participation. So I think there's a lot to be proud of there and always room for improvement. Thanks, Kelly.
Thanks, Beth. And I think, do we have room for one more final question? Excellent. Joe, this is to you. Can you please give examples of how outcome harvesting informed your practice?
Great. Always happy to talk about outcome harvesting. Yes, it's been a really interesting methodology to use as a routine ongoing monitoring approach. And I would say that it really called to attention the change that was happening around us by constantly collecting those examples of change and reflecting on them during our biannual reflection processes. And often it highlighted routes that we had gone down when then we had hit a dead end and there was no more change happening, or unexpected change that had happened and that we wanted to follow up on. And these were things our colleagues were aware of, a partnership that maybe stalled or a new engagement from a champion that we wanted to continue working on. But having it kind of concretely there in your monitoring data gave it a lot more weight and then kind of called it to attention and created space for us to think about it a bit more deeply. And then also outcome harvesting was a key part of the data that we fed into each of our evaluations. So there were 2 other evaluations that we undertook. And in our year 5 evaluation, as a result of utilizing our outcome harvesting data, we actually rewrote our whole results framework and shifted our emphasis away from demonstration work and more onto the system strengthening and wanting to create that sustainability and the opportunity to hand over to other people and to phase out of changing the way we care being so much at the forefront, and definitely outcome harvesting and capturing that long change process gave us that key moment to pivot as an initiative. Thanks.
Excellent, Joe. Thank you. And now we will move on from the Q&A and begin to wrap this up. I believe I'm handing back to Florence.
Thank you very much, colleagues. for this really rich presentations. I want to say thank you to all of the Changing the Way We Care team, both those that are present and presented today and those who are not present. You've shown such an incredible commitment to learning and to documentation, and you've addressed not just what was done, but the how, and also importantly, the areas where you were not able to advance as you expected and had to make changes. And I think this is exactly the kind of learning that as a community we need to do more of, and we need to document more of, particularly as I mentioned earlier, as we're coming as a movement to have a global care reform campaign. The learning that we're doing as practitioners, as organizations, as partners, as care experience actors is absolutely critical to this. So we want to thank you very much for this amazing webinar and learning. Clearly, it could only capture some of it. So just a reminder that we will be sharing the report of the evaluation with you as soon as it's available. We will also be sending the webinar recording and the slides and as well the Spanish version. There's going to be a survey that we hope you will be able to fill. It will appear after the webinar closed and in your emails. We appreciate any feedback. That's what's helped us learning as well. And the other thing I wanted to mention, Alina in the chat box highlighted there is an entire page on Changing the Way We Care, and under there is a huge amount of learning. Those tools, those guidance, those evaluation, those mapping that have been mentioned are all listed under there. So there's a lot of learning as well to be done through those, and we encourage you to look at those. We also encourage you to reach out to us and let us know that you've got learning that you want to share. And this is going to be part of this webinar series. This cannot be done without you putting your hand up and saying you're willing to share that learning with others. So we thank you in advance. Finally, there is a webinar, another webinar that's coming up on October the 23rd. And it is going to be focusing on the practice of kafala. And we really would love you to join if this is of interest. It's a critical part of alternative care systems in many contexts. And we would love to have you join us. Thank you again to everybody for their work in this webinar, and to the participant for brilliant questions. And let's continue the learning together. Thank you.